Hello everybody. Over the next half an hour, we'll discuss celebrity screening using whole body MRI, do's and don'ts. The title is not very accurate, is it? We really ought to be thinking about this in a different way. These are the do's and the don'ts of whole body MRI for opportunistic cancer detection. And why am I removing the word screening? Well, the WHO defines screening as the use of a simple test across a population to identify individuals who are asymptomatic, whereas early detection is quite different. This applies to an individual to detect disease before it becomes incurable. And because early detection can be in symptomatic or asymptomatic people, it is sometimes called opportunistic when you have, say, a raised PSA level, or it can be clinically suspected. So the learning objectives today are to list the potential of whole body MRI in this detection setting, describe a standardized protocol aimed at early cancer detection, explain to you the Onco-RADS system, which is a classification and a decision support system, show you some validation of the Onco-RADS system in this setting, and identify measures to decrease the harm of overdiagnosis. So these are my disclosures. So we know about screening. Screening is run on economic grounds for population benefits, and you can see the common cancers that are screened up on the top left. On the bottom left are the cancers that are not screened. These cancers, bladder, kidney, are not economic to do. One of the reasons why we don't screen for them. So the benefit for an individual of undertaking opportunistic cancer diagnosis is that you may detect cancers at a lower stage, and with appropriate and targeted interventions you can modify the disease course. So you get peace of mind, alleviation of health anxieties, could be important for retirement planning, insurance and mortgage procurements. The harm, of course, is overdiagnosis. Overdiagnosis of indolent cancers, and then investigative costs which may in fact fall on the patient or may fall on a healthcare system. But remember, the harm here is at the individual level, not at the population level. So what we're trying to do is to go away from what is community care, where too many patients seem to present with very advanced cancers, and stage 4 cancers, for example, presentations in prostate cancer can be up to 35% in the UK, for example, and bring that forward to an early diagnosis setting, and but not quite at the moment, to the population screening. So we're trying to shift this diagnosis point to the left so that we have fewer patients who are diagnosed too late, and at the same time trying to minimize indolent cancers. So is MRI suitable for this? Well, we know MRI has a high sensitivity for cancer detection. Any high sensitivity test at a low disease prevalence means that the negative predictive value is very high. That's a statistical truth. And of course we know that whole body MRI has an inbuilt characterization ability. In other words, the specificity is quite high, and that helps drive down false positive rates and therefore tip this balance between harm and benefit. But of course, whole body MRI has to be done in centers with good expertise in cancer imaging, with detailed history taking and where clients can be managed if they have suspicious findings. So does whole body MRI in this setting detect cancers? The answer is yes. You can see on the bottom right that the prevalence of cancers is about 1% in this systematic review. What is the flip side of that? The flip side of that was that 30% of people coming along for whole body MRI screening needed investigation. So what we're saying is that we investigated 30 people or 31 people, and one person got the benefit. Now, why does this occur? This occurs because older protocols, and you can see those dates on the left-hand side, relate to screening as performed before that publication date, obviously. And at that time, we did not have modern technologies. So trying to tip this harm-benefit ratio is important. And how do we go about doing that? Well, we can do that with whole body MRI because there's automation involved, there is AI acceleration and assistance, we have diffusion imaging, and we have Dixon protocols. And finally, more recently, we've now got reading standards and decision support tools. So what are these measures that we can use? For whole body MRI, there is a standard called the Onco-RADS standard, which you can see was published in 2021, which gives us protocols for standardization, interpretation guidelines, and decision support. So what does the protocol look like? Well, here is a typical protocol aimed at cancer detection. You can see we start off with a sagittal stir and T1 of the spine, brain, quick brain, 1 minute 50 seconds, without fat suppression, breath hold, lung images, 16 seconds. And you can see a couple of windows that you can use on that sequence. A T2 of the whole body from the top of the head to the mid-thighs, 4 minutes and 12 seconds. A vibe sequence in multiple stations. You can see we did 16 axial sections, and the total time is 1 minute and 36 seconds. DWI with 2B values, a calculated ADC, a coronal vibe sequence in 3 stations, 1 minute and 4 seconds, an accelerated stir haste sequence, 2 minutes and 32 seconds. That's it. So the total imaging time for 6 axial stations and 4 coronal stations in total, if you do breath holds, table moves, adjustments, the whole thing, the whole on-table time is 40 to 45 minutes at 1.5T. You can see that on the bottom on the left. So the Onco-RADS system goes beyond just giving you the protocol. It gives you a reading and interpretation guideline as well. So abnormal findings are categorized into one of 7 body parts. So the body parts are on the left. You can see the bones, the head, neck, chest, abdomen, pelvis, and limbs. Each finding and each client is categorized according to the Onco-RADS system, which you can see on the right-hand side. On the right-hand side, you can see Onco-RADS from 1 to 5. 1 is completely normal. 5 is malignant findings, highly likely. Now, 3, which you see here in the middle, is benign findings are likely. So it's not, I don't know. It's, this is going to be benign the majority of times. But there is a certain prevalence of significant disease in that group, and we'll describe what that is later. But the important thing is lesions and clients, each of them have an Onco-RADS system. Now clearly reporting needs to be done by oncologically trained radiologists, no doubt about it. We would highly advise double reporting of all scans. Stay cancer focused. Do not overcall lesions, because the prevalence is 1 to 2%. So you need high specificity reading because the pretest probability is very low. Categorize every positive finding with the Onco-RADS suspicion score from 1 to 5. Use a structured reporting template and have a clear summary on the overall assessment at the patient level, indicating the patient level Onco-RADS score. Remember to include things like the recommendations for any next steps and statements of limitations and appropriate disclaimers. Okay. When should you adjust your reading for higher risk clients? Well, let's say you get referred a patient who had a positive multi-cancer detection test, such as circulating DNA, where they've looked at methylations, or circulating RNA, tumor markers. But remember, whole body MRI is the second test. It's never the first test. The first test might be something like a PET scan, or if the test says look in the ovary, then you want to look with a dedicated scan, for example. So it always will be the second test. Older age people, you need to be careful about. If there are certain risk factors, such as long smoking histories, alcohol consumption, exposure to viruses, and occupational exposures, if there is a family history that goes beyond the cancer detection syndromes, if they have had surgery or cancers in the past and they're no longer on active follow-up, these patients you need to be a bit more careful about. They are at higher risk. Let's say you had an abnormality with negative investigations, and that changes. You'd want to be careful about that. Okay, so there are higher risk clients who require higher sensitivity reading and maybe even an increased frequency of return for rereading. Now, there is a template in the Onco-RADS system, and you can see that laid out here, and you're welcome to look at the paper, but it's, I think, much better illustrated using an actual report. So you can see this is laid out the way you should try to lay it out. So the indications are up top left, any technical note, findings, head, neck, chest, abdomen, pelvis, etc. You can see that every lesion has an Onco-RADS score. So multiple splenic cysts, Onco-RADS 2. Incidental vertebral hemangiomas, Onco-RADS 2. Conclusion, there are no cancer worrying features on this whole body MRI scan, Onco-RADS 2. So you can see how we've laid it out as it should be laid out. Every lesion is given an Onco-RADS score, and the client is also given an Onco-RADS assessment. Now, disclaimers. You need to have disclaimers for men and women separately. So, for example, you can say things like whole body MRI can miss small cancers, hence it is important to be looked at a physician who takes a holistic view and provides long-term care and advice. You can say that cancer-specific tests for specific body areas should be undertaken, such as colonoscopy, stool tests, mammography, cervix smears in women, for example, and can detect in specific areas. Okay, and then explain at the bottom what is actionable according to the Onco-RADS score that you have given. Okay, so this is the decision support tool. You can see that we are dealing here in the general population. If you have Onco-RADS 1 and 2, the probability of cancer is very low, no follow-up is required. Onco-RADS 3 may be called intermediate, but actually is benign findings highly likely in this group of patients, and some of these may require clarification of findings. I'll show you an example in a second. Onco-RADS 4 and 5 is clearly actionable, and you need further investigations with or without a biopsy. So, What are the common cancers that you would expect to find? Well, it'll be the cancers that you have in the general population. Okay, so you will get all of these sorts of cancers detected, minus blind spots that whole body MRI can't see, and that's important to remember. So these are small GI cancers, small breast cancers, the thyroid nodule, some smaller lung cancers, and some specific histotypes that you may not see as well. And I'll show you an example of one of these shortly. So look at this man, 65-year-old, fit and well, non-smoker, family history of bladder and lung cancer, and look what we find in his left kidney, a 7.5 centimeter kidney mass, clearly an Onco-RADS 5, needs urgent urological referral, and this turned out to be a clear cell carcinoma, and he underwent a nephrectomy. What about this man? 49-year-old man with reflux symptoms, and you can see, if you look at the diffusion sequence, quite difficult to see anything on the MIP image, but if you look at the axial images, you can see a mass at the lower end of the esophagus, not so well seen. This is clearly an Onco-RADS 5, but the histology is a colloidal carcinoma, which is why it's difficult to see. This is somebody that I saw recently, 38-year-old woman, mother had breast cancer, age 58. We find two abnormalities. We find something on the MIP sequence here, and this is the lesion here. Clearly this is a cyst in the breast, so it's a simple breast cyst, Onco-RADS 2, but we also find a complex appearing syringomyelia, probably related to the cerebellar ectopia, but we would want to give this contrast because you want to exclude the presence of a tumor causing that syringomyelia. So this patient needs a contrast-enhanced spinal MRI scan and a referral to a neurological multidisciplinary team meeting to see what this is. So this would be classified as an Onco-RADS 4 abnormality. What about this lesion? 25-year-old, fit and well, no strong family history, has a screening examination, and has something in the proximal humerus. You can see it here, and here, and here, and there obviously a cyst. So this is likely to be a simple bone cyst, but requires further evaluation. So it's an Onco-RADS 3 and requires an orthopedic consult for that, just to be sure that that is in fact just a simple bone cyst, especially if she is asymptomatic. What about this guy? 44-year-old, fit and well, non-smoker, no strong family history, has his annual screen, and you can see there's an abnormality here in the left side of the thyroid, and here it is on T2. So this was classified as being non-complex Onco-RADS 2 in 2022. In 2023, we see the lesion is larger, and there is a papillary projection within the lesion. So this went from an Onco-RADS 2 to an Onco-RADS 3, clearly a changing Onco-RADS score, had an FNA biopsy, it turned out to be a papillary carcinoma, had a thyroidectomy. So you can see how a changing Onco-RADS score is important because it could signal something more sinister in the background. And this also applies to this lady, 46-year-old, fit and well, smoker. She had a history of a HER2-positive breast cancer on the right side, was no longer on active follow-up, apparently cured. She's worried, undergoes serial whole-body MRI scan. She had a scan in 2022, then 2023, and now in 2024. And look what happens in 2024. A lesion appears in the right chest wall. Here it is on the B900, the T2, and the ADC map. This is clearly a recurrent cancer, biopsy proven. She underwent a bilateral mastectomies and reconstruction. So, using the Onco-RADS system is in fact quite effective in both retrospective as well as prospective studies. So here's a retrospective study. You can see that 2,000 subjects who were cancer-free were followed. You can see that the prevalence of 3, 4, and 5 was 5%. Here we go. 3, 4, and 5. Add these figures up. It's 1 in 20 were classified as having Onco-RADS 3 to 5. Okay. The second thing you'll notice, as the number of cancers diagnosed increased as the Onco-RADS suspicion score became greater, which is what we expect. So for Onco-RADS 3 it was 5%, for Onco-RADS 5 it was 7.5%. What was the overall prevalence of cancer? 1.2%. So very similar to what we saw right in the very beginning. So what we're saying is that you do find cancers that are actionable, but the total proportion of patients that you're investigating is going down. Remember, it was 30% before, and now we're down into 1 in every 20. Here's some prospective validation. This was done in Italy, and what you notice is that the prevalence of cancers in Onco-RADS 3 in this study was 2.5%. In the retrospective study, it was 5%. Okay, but as the Onco-RADS score increased, you can see that the prevalence of cancer also increased. But if you look at the overall prevalence of cancer, it's 1.9%. So in other words, what we're saying is that the prevalence of cancers in this kind of population is going to be between 1 and 2%. So what are the do's? Do make sure that you use a cancer-focused protocol. 1.5 seems to be preferred. Do consider benefits versus harm, very important. Use whole body MRI alongside standard screening tests. Remember to counsel your patients on the potential for incidental findings. And do manage expectations of your patients, letting them know that you are not doing a whole body scan, but a whole body cancer detection scan. Quite different, right? Because a whole body general health checkup is very different to a whole body cancer screening focus. So for example, just to illustrate that very briefly, you'll see that a general checkup is looking at all kinds of stuff. Looking at your likely cardiovascular risk, your muscle to fat ratio, the detection of incidental serious abnormalities such as aneurysms, and you're trying to promote general health in these patients by informing on their lifestyles. A whole body MRI cancer screening protocol is very different. Here you're looking at the detection of cancerous lesions for timely interventions and the surveillance and monitoring of people who may have cancers as well, or have the Framini syndrome or other familial syndromes. So in fact, they are quite different. So do develop collaborations with your referrers. Make sure you have a detailed health questionnaire. Double read every case, it's important. Use structured reporting. Do be prepared to deal with aesthetic implants and the complications of these aesthetic implants. You need to be very clear how you talk to your physicians. Charge for your time if your patients or if your clients want to speak to you as the radiologist. Remember to have an alert system for abnormal findings, particularly Onco-RADS 4 and 5, for onward communication, and do publish your results on cancer detection rates and satisfaction rates, etc. Because remember that not everybody is convinced about the opportunistic screening using the whole body MRI approach. What about don'ts? Don't use whole body MRI instead of as a substitute for cancer detection pathways. Do not interfere with patients who are on active cancer follow-up. Do not over-investigate incidental findings that are detected in the opportunistic setting. Do not interpret whole body MRI if you don't have oncological imaging expertise. Don't oversell the benefits. Don't read whole body MRI without having enough clinical information. Remember, you need to know what surgeries were done, what the family history is, and make sure the whole thing is wrapped up in an informed consent procedure. Don't give IV contrast for this sort of procedure. It's better to recall patients for certain specific examinations if they are needed, but those are dedicated protocols. Do not leave a patient with an abnormal finding, whatever Onco-RADS, without an adequate explanation, because they'll go on to Google and they'll just go crazy. Okay? Do not use whole body MRI as the only reflex test after a multi-cancer detection test. And you can see a multi-cancer detection panel on the right-hand side offered by the Cleveland Clinic, for example. Okay? Do not sell the data of your clients, and remember to work under an ethical framework. So here are my 5 golden rules. 1. Cancer-specific protocols. Number 2. Expect to find abnormalities in subjects with 1 in 20 needing a further test, but remember, less than 2% of people will have a cancer. Number 3, use Onco-RADS reporting and decision support guidelines and have a high threshold for further investigations depending on the likelihood of cancer. So I showed you those patients who are more likely to have higher risk. So for them you may want to lower the threshold. For anybody else you want a higher threshold for investigations. Remember that you need to have defined protocols on the 5% or so clients who would have these Onco-RADS 3 to 5 abnormalities, and remember to have people who follow through with the findings that you detect. Remember, this is best performed by cancer imaging experts and have established pathways for the onward care of your clients. I hope you found some of these comments useful as you think about how you might incorporate a technology like this in your own practice. Thank you very much for listening.